Hello, everyone, and welcome to the Troubleshooters podcast. So, today we have Bryan with us. Bryan is a friend of mine and also one of the leading researchers and academics in health service delivery. A bit about Bryan's profile. So, Bryan's currently the strategic program lead, placements for NHS education, and formerly an associate professor in research, and has previously occupied the role of associate dean twice, and has been a reader in organizational behavior and management. Bryan has previously worked in central government, the NHS, local government, and at various academic institutions within the United Kingdom. For today's podcast, we will be discussing bottlenecks in efficient health service delivery. Bryan and I have had multiple discussions on efficiency and effectiveness of service delivery, so I thought this might be a perfect topic for today. So, Bryan, first question is, according to you, what are the bottlenecks in efficient health service delivery today?
Thank you for that introduction, Anjali. You had me gushing at one point, but thank you very much. It was very kind of you to be so nice. Thank you. To answer your questions, this is a multifactorial issue that creates bottlenecks. There's often a misunderstanding. There's a confusion between leadership and management, one factor. There's a confusion, there's a misunderstanding of the strategic aim and operational objectives. And there's a misunderstanding between the natures of supply and demand. And that is wrapped by two other factors, structural inequities and structural failures, both geographically and disciplinarily. And I'll come back to that in a little bit, in a bit more detail. Now, in the first part about leadership and management, it's a clear vision and a clear plan of action. In government, you'll usually have a 10-year plan. Often it seems in Britain, particularly in England, the National Health Service goes from one crisis to the other, and there's conflicting approaches. And these, by their very nature, create bottlenecks to delivery. All delivery must be simple. The more linear, the more simple it is, the more from delivery to user in any sector, the better effectiveness is and the better efficiency is. So people can notionally make something more efficient, and it will look more efficient, it will seem more efficient, but will not be more effective.
Yes.
NHS is littered with examples of that. And during COVID, we've seen that very much, particularly in relation to testing. Testing on paper looks efficient, but it's highly ineffective. There's no doubt about that. And a massive waste of money as well. No doubt about that as well. Then there's the strategic aim and the operational objectives. Now, in classical theory, strategic aim should always be paramount. But when the interaction between the theory and practice, operational necessity trumps strategic objective every time. Every time. And that creates massive bottlenecks. When that's exacerbated to the structure, in England, we're talking about England, there's far too many trusts. Now, the government's going to address that. Now, that means at the moment there's about 40 plus trusts. It should be ideally, it should be half of that, and it should map on to the geographical local government structures. So you would have a regional trust. So you'd have the northwest, the northeast, the southeast, the southwest, London North and London South. London's so big, so you would have it maybe even 2 or 3, maybe 4, but it would be dramatically reduced rather than having fractures within fractures. And these fractures within fractures create tensions, which create blockages. Now, I'll give you an example. I often use this in briefings to government. I often describe the NHS trusts as like a bad episode of the Game of Thrones. They're all competing with each other. They're fighting turf wars. These are multi-billion-pound organisations.
Yes. A lot of funding.
Multi-billion-pound organisations. Some of them have assets worth not hundreds of millions of pounds, but billions of pounds. So they're unwilling to take. They're always good. They will always preserve their own, what they perceive to be their self-interest, rather than the strategic national self-interest. When I was in government, I used to have, I'll give you this anecdotal story. I used to have meetings with chief executives of trusts, chairmen of trusts, and they would talk about their trusts, their trusts, their trusts, their trusts. And I was once with a minister who will remain nameless, and I was getting a bit bored by this. So I said, "Is that who you serve?" And he says, yes, we serve the interests of the trust. And I said, "We serve the interests of the British people who put us into power, who can sack us and we can sack you." Now, the solution to that problem, just very briefly, if you can indulge me, about how to solve that blockage is moving chairs. Do you know what I mean by moving chairs?
No.
There used to be a game when I was a child where you would have
musical chairs. You play a song and
musical
yes,
chairs.
I do know that, yes.
Musical chairs, and they would play music,
yeah.
and they would move the chairs. Sometimes musical chairs or moving chairs, and you would start off with 6, and then you'd have 5, and then you'd have 4, and then you would have 3. Take the chairs away, merge them. It will be quite traumatic for those involved, but the effectiveness will be immediate.
So, Bryan, just one thing, because I think a lot of people are unclear about what is efficient healthcare and what's effective healthcare. So could you quickly just put that into context?
Efficient is often notionally driven by the bottom line financial figures. So you can have something that's on paper that's very efficient. But actually it'll be only efficient in the short term. It's financially efficient in the short term. I'll give you an example of this. If you invest strategically in mental health, which is very popular, what you want to reduce is the readmissions.
Yes.
So you can make, on paper, we're running this service efficiently, but it does not factor in readmissions. Once you factor in readmissions, it's neither effective or efficient. It depends on where you take the snapshot. There's a concept in statistics called the tyranny of aggregation. When you aggregate data together, it will naturally deceive you. Often people that look at efficiency are naturally deceived because they will be looking at a particular time from a particular position. So I hope that's clear about the difference between efficiency and effectiveness. I would always argue, so really what you wish to reconcile is effectiveness with real efficiency, so that you have the cost efficiency by reducing readmissions. I'll give you an example of this. Imaging and scanning. Everyone accepts that diagnosis early diagnosis has the better outcomes for
Yes.
the patients. It also has a better outcome for the service, because if you have someone who has had a stroke, depending on which kind of stroke that they've had, you can put into place systems that preserve that person.
Yes.
And reduce the amount of care that person needs.
Yes.
If you do that, the the real costs become negligible. But so it's all this short-termism, invested interest. I'll give you an example. The big major structural change that will happen in the NHS is in nursing. That will be a massive change. What we call nursing is fundamentally different from 100 years ago. Nursing is fundamentally different from 10 years ago. But we still use that term nursing as a catch-all. The real nursing is I don't consider them ancillary workers, because they're not ancillary, they're core workers.
Yep.
But the care assistants are currently providing most of what was historically termed nursing. What you have in advanced practice, which is in essence paramedicine or junior doctors, is where we are currently. Now, with artificial intelligence, the use of artificial intelligence and the greater use of technology, that role, that paramedic role, will not just be utilised in relation to accident and emergency, but we're embedded within the framework body corporate of hospitals or communities. Now, the other big bottleneck is hospitals. You go, goodness, how can a hospital be a bottleneck? Well, it is a bottleneck. One thing COVID has showed us, very clearly showed us, is that we have more than adequate bed capacity in the hospital system in England. Without a shadow of a doubt, that's shown us that. There was always more capacity. When in the early stages of the COVID crisis, they prepared and built very quickly new hospitals.
New hospital, yes.
Not one was utilised for its purpose. Were used for other purposes, for cancer screening and other important, but they were not used for that. They were not used. Now, if you have technology, if you have artificial intelligence, if you have community provision, it's more efficient, more effective, and maintains the independent integrity of the individual. Now, that's very, very important. Now, why do hospitals create bottlenecks? Because of their arcane structure. I'll ask you a question. I'll ask you two questions. Do you have a fax machine in your house?
No.
You don't. Who do you think the largest owner of fax machines in the world are? The world, not even in the UK, in the world. Who do you think they are?
I'm guessing by your question it's the NHS.
It's the NHS. Fact. Do you know why they're the largest owners of fax machines? Because they still use them to fax over instructions. Fax. So, for example, prescriptions. Now, that fact says it all. It is like having digital technology and using the quill.
Very much.
Now, that can only happen if you have structural demarcations, which are so rigid that you will only accept a signed copy of an instruction. So you have to sign it and fax it. So you've got that copy. That's neither efficient nor effective. How could that time be justified on a consultant on £120,000 a year? Signing something, faxing it. Nonsense. Total nonsense. Now, that can only exist in a stratified structure with very powerful, and I talked about that in my introduction, actors and agents. We still have a very stratified system in medicine. They often, doctors are still, and even more so, considered as many gods. I consider them to be jaded mandarins. That's how I consider most doctors, jaded mandarins, or little Buddhas, more accurately, a little Buddha. They're dedicated, I acknowledge that. They are dedicated career professionals, but they are normally dedicated to their discipline. Rare is the medical professional I have met, and they've been brilliant, that looks at the strategic needs of the organisation. By their very structure, they'll either look at the needs of the patients, great, fantastic, absolutely necessary, but they will not take the pause to think, well, what needs to happen strategically. Other bottlenecks, the hospitals are all in the wrong place.
I had a conversation about, in fact, one of the guest lectures we did, Adam and I were talking about this, saying, because I was a student, and for me to get to the hospital with public transport was a nightmare. Because they're not accessible at all, unless you own a car and you drive a lot.
Yeah, they were all built in the 1980s, 1920s. There was this, you need to build hospitals where there's people. So in the 19th century, unsurprisingly, most of the hospitals were built where the people lived. Now you have them on the periphery. They don't live. Now that's easy to build them there. It's easy to build a completely new build. But most of them, and also they are, in essence, the wrong kind of hospitals. I'm a great believer, we're talking about bottlenecks. Right? I'll give you an example. So I go to the GP, I've got a cough, my lungs are a bit dodgy. He says, we'll send you for an x-ray. They've not got an x-ray in the GP practice, so they send me to the hospital, send the results back, get that, something like, we'll get further investigation, they send me to the hospital, and then they send me back to me. GP, central owner of this process. In Germany, the Netherlands, Australia, there's a cascade system. You would never have a small GP be a 1 or 2 person GP practice. You would have a consolidated GP practice, a little like a mini general hospital,
with basic facilities.
A polyclinic. So you would send the person for imaging and scanning. You can get done instantly. It speeds up diagnosis, makes it quick. Now, that need not be expensive. It needs not be incentive. All you have to incentivize is the tariff system to make it. The means to achieve these things are very easy. You have a tariff. You can pay a tariff for any system. You incentivize the tariff.
Everything else will fall into place.
Everything else follows the money. Everything follows the money. So you don't give it to the trust. If you want to reduce the power of the trust, you can do that overnight. You have the patient pathway. The money follows the patient pathway. Simple, radical. The solutions are logical. Applying them because of the politics is extremely difficult. Now, I often talk about the RC. I have a love-hate relationship with nursing. I have a love-hate relationship with them. By the way, my family are nurses, I hasten. A lot of my family are
Your
nurses.
PhD was also on nursing, right?
And my PhD
Yeah.
examined the nursing workforce,
Yeah.
the whole nursing workforce. And I've never been a nurse, I hasten to add, but I do have a love-hate relationship with them. I once wrote a paper that said, "Argue your own worst enemy," which I had to change the title for, by the way. But are they their own worst enemy? Why do I have a love-hate relationship? Because they are so entrenched in the past. The least, on one level, about changing certain things. So they make the system more difficult than it needs to be, or it should be. And I'll give you a couple of examples of that. When I was doing my PhD, I would interview all these wards, all these nurses, and one day I got invited. They were doing. I shouldn't have been there because that wasn't in the nature of my PhD. My PhD was on career outcomes. But I was there and they were doing this exercise about who was the most efficient and most effective. And I was there, and because I was an academic, they asked me as a critical friend to review it. Now, the one that was the nurses were more, there was this ward manager who they were all didn't like. I loved her, by the way. They didn't like her. Our fellow nurses. And I learned a lot from her. What she did is she let the patients get up when they wanted and made their beds in the afternoon. Now this has got to sound so minor.
I can see how that will affect patient outcomes. Yeah.
It was massive on patient outcomes. She had the best patient outcomes because they slept longer, were more relaxed, and had more control over. But the other ones had quite a regimented regimes. They woke them up at 6:30, fed them, washed them, and let them stratify for the rest of the day ward. Now, you just pointed out why that would have a massive impact on patient outcomes. Now, to me, it would be logical you gave that autonomy to the managers, but what the other ones said, well, we get the food up at such and such a time and we would just be lying about and be cold. This is where you've got microwaves. The patients, although it's cold anyway, it comes up cold. It's milk, cereal for breakfast. Teas, you've got running hot water, let them have it. Now that would be a very subtle change, but maximum impact. Now that's a very, now that's how to think. That's just viewing problems and having a patient-centered. What the default system was the past. Now, if you've got a world in which you have Zoom, we are speaking on the joys of Zoom. We have artificial intelligence, which can give you predictive modeling. All these things, but yet you're not willing to change a practice. You're still using fax machines. Fax machines.
Yeah, I had no idea about that. That is
fax machines, because you still want a signature, because you've got to want to see that signature because of the NMC. Now, I was just doing somersaults and break dancing because I've been advocating it for years. When I had the joyous news that the NMC was getting scrapped. I have to admit, I have never come across a more obstructive body in my life that create bottlenecks. The question is bottlenecks.
It's not. What I can see very clearly here is it's not any of the professions in itself. It is the people who are setting the rules and the
who are
guidelines
naturally
for the
precisely.
So
it's the bureaucracy.
It's the bureaucracy which is a problem. It's not the individual nurses or not the individual doctors. The problem
precisely. It's not. It's a systemic issue in relation to bureaucracy, because some people are natural bureaucrats and they will create a bureaucracy for legitimate reasons to reduce risk. But when does the bureaucracy become the enemy of innovation? When does it become the enemy of productive and beneficial outcomes? There's many, many examples of it. But what you have is bodies and institutions that are lacking critical thought about their own purpose. And there is and the end of the NMC's no great tragedy, because there's inbuilt obsolescence to everything. Even me, there will be a time there'll be some young person, much brighter, better, taller, thinner, more handsome, that will replace me. Quite right. I have an inbuilt obsolescence. So do systems. There's no system that survives unaltered forever, despite the best efforts to preserve it. Bureaucracy is used as the spinal skeleton to preserve organizations. All I need to use is 2 words: fax machines.
Right, just one thing, because of course one of the things that often two things that I've seen come up in media or articles a lot is, one is waiting times in the NHS, and when we are looking at bottlenecks, I think that there has to be a reason why it can't just be lack of resource. I know we have lack of resources, but I don't see that as the only reason. And the other
Sorry.
yeah, and the other one is that, okay, we need to hire more people, but again, is hiring more people going to solve this? So that's something I wanted you
Well, you raised 2 very good points. Waiting times are a misnomer. I'm going to tell you exactly why they're a misnomer. I'm going to use ambulance service as an example. You're supposed to get a machine out. You're supposed to get an ambulance out within 4 minutes, 5 minutes for your initial call. There's this thing called perverse system. This is a perverse system. It's better to take longer and get the right person with the right skills to the right incident, rather than just saying a prescriptive model will get one out. The key is to get the right person with the right skills at the right time to the incident. So, for example, if someone has a cardiac malfunction, a massive heart attack, you want a person with cardio skills out there as fast as possible. So what you have is, what you really with that kind of thing is, you want a warning code. So what you want is a person that takes the call to take longer to find out exactly what's happening. Instead of saying, it's an accident emergency, we need an ambulance, send an ambulance. If a person's had a stroke, what kind of stroke? If they've had a heart attack, if they're in an accident, what kind of, taking that extra longer and getting the right thing at the right time. Now that might seem so obvious, but once I see it, so that's why I'm against no waiting times, response times, I should say, for that. In relation to waiting times, it goes back to my earlier proposition I put to you about our structural difficulties. We have massive hospitals, but bureaucracy. So by the time you get to treatment, the person has had to have 45 steps. If you have a polyclinic, you go in, there's an imaging and scanning machine within that facility. It's important. We'll go to the imaging and scanning. Come back tomorrow. Come back 3 days. I'll give you an example of this. For years and years, what built my reputation, if I have a reputation, is telemedicine.
Yes.
I came up against massive opposition by the Royal College of General Practice. I mean, industrial levels
Mm.
of resistance by the Royal College of General Practitioners. Industrial level. I mean, it's well documented in the press. COVID-19 happens.
Telemedicine's in.
We're never going back. People are not going to go back to queuing for a week to see a doctor face to face when you have Zoom, when you have a phone call to make. We have too many general practitioners in the country. We always had too many general practitioners. We had too little when we used the 19th century system rather than the 21st century system. Once we use the 21st century system, we've got more than enough general practitioners.
It's about
The lesson speeds up. Instead of waiting 2 weeks to see a doctor, you see the doctor on the same day. By cutting the Gordian knot. No sacred cows. No sacred cows. No vested, and the more powerful that vested interest, the more I want to tackle it. Do you understand? So you've reduced it. If you have imaging and scanning facilities, by the way, I think we've got too many doctors in the country. Too many. Because what I want to invest in is artificial intelligence, the imaging and scanning. The machine mode. Right. The other thing as well, look, God forbid anyone gets cancer. God forbid, it's a horrible disease. But it's massively, because it's such a horrible disease, there's a lot in research investment goes into that. But most of the diagnostics are imaging and scanning.
Scanning, yes.
Particularly scanning.
Yeah.
That can be used for diagnosis of dementia.
Interesting. Okay.
Actually, retinal scanning can be used. Retinal scanning. So when you go to get your eyes tested,
yes.
you can use that facilities for testing for
early
dementia, early stages of dementia. You can take teeth extraction. The dentine will tell you your predisposition to dementia. And technology is already there. It's already there. But so what I would do cancer research is like a sponge, will use up all the resources. If you're government, you say you create a sessional rule saying that 4 sessions out of 11 will be on dementia research of any NHS facility. It changes it overnight. Another thing COVID is right that has shown us is a risk aversion to the point of paralysis previously. We got the drugs out super fast.
Exactly.
Sure, it can be done. Shows it can be done. The delays cost lives. But that is because you've got institutional actors which are completely risk averse to the point of paralysis. Now, if you if you reduce by half the amount of bureaucrats, you reduce by half the amount of bureaucracy. I can assure you, because you just can't do it.
Yeah.
So if you talk about bottlenecks, by merging the trusts and having one unitary authority, cap numbers on that unitary authority as well, cap numbers, you'll reduce the amount of bureaucracy. Deregulating the system allows for innovation. Now,
I was actually going to talk about deregulation as well, because from the conversation we've just had, a lot of the issues seem to be the fact that someone somewhere is making the decision that everyone has to follow. there is no scope for, let's say, a particular practice or a particular board or them to, innovate and make changes and test it out.
Yeah, they do have it,
Mm.
but because the NHS is so big, it never. I mean, there is a tendency, and I can understand why this developed historically, for a one-fit-all approach. But the NHS is so big that it needs to be deregulated. And there was things that were so obviously a mistake, like PFI, public finance, the public-private financial initiative. These were such, clearly, at the time I was completely resistant to them because it didn't make sense. It allowed the building all these new builds in godforsaken places.
Yeah.
Now, you live in Darlington. What's the nearest hospital? Darlington General, is that the nearest hospital?
I see in Doncaster, but Doncaster one's surprisingly easy because it's right in the middle of town, but it's the only trust I've seen right in the middle of town.
And is it an old building?
Yes, it's a very old. It's a Royal Infirmary from ages ago.
So it's an old building where there's people. And when you go to the Royal in Edinburgh, where I was born, you have the Royal Infirmary that used to be in the centre of the city. Now you have the Royal Infirmary in a place called Little France. It's in the back of beyond. You can't get to it unless you drive. It takes you an hour to get there from the city. No purpose to it. So, what you again, smaller polyclinics, no small GP practices. The minimum medical staff in a practice, in my opinion, should be 50 doctors. And it should cover a big wide area. It should be like a small general hospital that they had historically. But with not just seeing doctors, but
diagnostics.
That's the key, diagnosis. And even some treatments. They can take their bloods, etc., all these things, but mostly diagnostics. Because it's that need to have the diagnostics that can make the big difference.
I can see how that helps, because I think I've always been talking a lot about taking care closer to the patient rather than away from them. And this falls in very well with that system of how can we have it within a 5-mile radius of people where they live.
This might have changed with COVID, but historically, where do you think the most amount of diagnoses for cancer took place? Where do you think they took place? Do you think they took place in the general practice? How do you think that a person found out that they had cancer?
Emergency?
Accident and emergency.
Because they would have gone in with something severe and then got diagnosed for cancer. Yeah.
So the majority, which I find the most shocking case, and I've seen it in people that people that I've known throughout my life, they've had to go into the hospital for one condition, and then they've given them a basic X-ray and found out they've had some kind of cancer or a CT scan. That is shocking. That tells me the system isn't fit for purpose. And we talked about cancer. Have you ever heard of a singer called Bob Marley?
Yes.
Now, you know what Bob Marley died of?
No.
Died of cancer when he was young.
Okay.
Much younger than I am now, in my hoary old age. Now, do you know where Bob Marley had his cancer?
No.
He had it in his toe, his large toe. And he didn't have treatment for a whole host of reasons. Now, if that was me, I would be saying to the doctor, cut off wherever you want. Cut the foot off, cut half the foot off, cut below the knee if you want. Bye-bye foot, bye-bye toe. It's going to save the body corporate. Now, what you have is a cancer in the system that is poisoning the body, and it has to be cut out. Because if you have a situation where most cancers are being told to the person in accident emergency, or when they're out of accident emergency on a ward, that tells you the system's not fit for purpose. It's
We're
not
missing somewhere. We're missing the link. We're not catching it where we should.
That's why I keep saying you catch it at the early stage. You go into a GP in a house, or basically it's most GP practices are old homes that have been converted.
Yes.
I mean, most of them. I was growing up, it was an old house. You would have maybe a practice of 2 or 3 doctors. Totally unfit for purpose. Totally unfit for purpose. What you want to have is a mini hospital, 10, 20 hospital doctors who can see patients virtually, face to face, get them in for scanning, have radiographers, pathology, and then you can get them to treatment. The big hospitals, treatment, not diagnosis.
Not diagnosis.
So diagnosis and so what you have is a root situation. Think of a tree. The tree is the what you see outside the big hospitals, treatment. The root system, the polyclinics.
It can be a lot more cost efficient as well, because if you're diagnosing things early, and a lot of chronic diseases and issues we face are preventable to a great extent, or preventable from getting too far. So if we catch it early, then we are effectively saving cost in terms of long-term treatments.
Well, the other thing as well is the nature of the treatment. I'll give you an example. The system that has the most amounts of diagnosis, but it's probably the most expensive, and I'll explain why it's the most expensive, is the United States. The United States, if you have a cough, you'll get a scan. I can assure you, I've lived in the US. So if you went there, they wouldn't think twice about sending you for a CT scan. You go over, you've got a chest infection, you might get a bloody scan. They're not taking any risk. But then they would, if you have any godforsaken condition, they will try every treatment before the most, which is normally the most cost effective. And I'll explain one that's quite common. And where actually this American system, actually, in my opinion, resulted in the death of the person. The person had prostate cancer. So in America, they tried pellets, uranium pellets, everything, so that the person still had the majority function. He was still relatively young, the age I probably am now, slightly older, in his mid to late 50s. Now, if I had prostate cancer, the one that's guaranteed to save my life is a radical prostatectomy.
Yes.
So that would mean that they would take the prostate away.
That would mean that's the best one option.
That is the 100% guaranteed. If it's no spread, if it's in it, you've got to live. You're not going to die of prostate cancer.
No.
You're not going to die of that. That will mean that you don't get an erection, or you might have urinary issues.
But you'll live.
You've got to live. You've got to live.
But you miss out.
So, but the Americans will say, well, you might miss out. And so they'll try the other treatments, which are going to maybe cost $1 million. Maybe more than $1 million. Some of them cost
very, very expensive. Yeah.
Very, very expensive. A radical prostatectomy costs about £10,000. So I mean, this is where you've got to see, well, that's a flawed argument, Brian, because what you want is to have function there. Well, when that technology exists, yes, we have it.
Yeah.
But at the moment, if you're talking about, so you gave if I was to say to someone, a man, well, in your late 50s, early 60s, well, you're not going to get an erection, or you can have a radical, but you've got to live.
You choose.
You make a choice. Most men are going to say, right, oh, where am I getting the operation? And I met a lot of my friends who are older than me have been in that very situation, and they've had that very choice, and they went in the more extreme procedure. But I don't consider it extreme. It is the one that's guaranteeing life. Still we function. And you can still see your children, still see your grandchildren, still see your friends, still walk there. And it's more effective.
Even the quality of life, it will be more effective than chemo, radiation,
Precisely.
anything else.
Well, if you get chemo, we use the most unsophisticated treatments, radiotherapy, chemotherapy, we either radiate or burn. Ultimately, that's what we're doing.
Yeah.
We're irradiating or burning, because that's what chemotherapy is. That's what we do. Exactly. And radiotherapy is. We burn or we irradiate. None are pleasant on the rest of the body. Now, nowadays, we can get very focused beams. None are pleasant. I've got to use some strong language here. I once had a preeminent physician who once said to me, what you're describing is the difference between shitty and really shitty. This isn't tea and cucumber sandwiches here. This is deeply unpleasant procedures. So, but then I keep going back to what the original sin is. The original sin that you have is that you have a system structurally that's still stuck in the 19th century. Stuck in the 19th century, stuck in the past, and the unwillingness to do the fundamental changes to develop it. GPs, remember, are private practitioners. The NHS is not, the majority of the staff in the NHS are not public employees, they're private employees. We've got to remember that. And if you could create a system where the payment for a GP, the payment is based on how many patients they have, and there's a cap tariff. I keep saying this, if you want to change things, we have the means to change it quickly. How we incentivize the tariff. If you top load the tariff to increase the payments for consolidated GP practices, the change will follow the money. Change will follow the money. It's inevitable. If you have a flat fee, it's irrelevant. You can add on the costs for your building. If you say we're not going to pay you any payment for the building, we're going to increase the payment for the number you have, and it increases the greater the amount the practice grows.
Yeah, it makes sense, because I think I'm very happy with my current practice now. It's very different from in the one I used to go in Coventry was very typical GP practice, nothing other than consults. Whereas this one that we go to over here, they do pathology over there. They do basic. They have a physiotherapy section on top, and there's two practices who have come together, and it's a big building with a lot of services.
That's the way. That's the future. That's the future.
It's just so much more comfortable. It's like I've never, unless for an emergency, you don't have to go anywhere else other than that.
Well, that's the thing. That's what you want is a small polyclinic, and ultimately what you want is, okay, for imaging and scanning you have to have a bespoke. For imaging and scanning you have to have a solid foundation building. You have to have it because of this ultra sensitive equipment. But if you were saying that you have these facilities and you use them not just 9 till 5, I want them 8 till 8, 7 days a week, if not more. So, I mean, the days of people with COVID, working patterns are fundamentally different. The way
and it's going to change. It's never going to go back to 9 to 5.
It's never going back. This is a revolutionary. This is I love using this phrase. The meteor has hit. This is an extinction event. It's an extinction event for certain processes, for certain ways of doing things. The dinosaurs have met the meteor. I always have a line, I sometimes use it, I say, The dinosaurs ruled the earth for 150 million years. They're extinct. Some of these disciplines have ruled the earth, ruled the NHS. They've hit the meteor. GP practice is never going back to what it was before. People will not put up with waiting 4 days to see a GP when during COVID they saw them on the same day. Why would they go back? Why should they go back? And this is a hard lesson for the GP. I mean, I feel completely vindicated, by the way. My smugness, which was always high, has went to industrial, the size of a small planet. Because I was right. I always knew I was right. I knew they were wrong. And I'm not going to have any, I'm not going to have any pretense there. I was right and they were wrong. And there's a reason why I'm doing consultancy in the Cabinet Office. There's a reason why I'm there, because I'm 100% right on these things. 100% right. Not because Bryan McIntosh is saying I'm 100% right, but because the evidence has proven me right. And people aren't going to go, would you go back to waiting 4 days or 2 weeks to see a doctor now?
No.
Nobody's got to do that. They've just got to say, well, we did it during this. Can you get them to phone me? And they've got to say yes, because they did it. The GPs did not have a great COVID crisis. If the truth be said. There's some people have had an amazing, I'll give you another example. In your original question, which we sort of developed from. There was a big debate about skill mix and skill max. And that skill mix and skill max developed from what was called the RN forecast. This was about 15 years ago. It was, the question was raised, and there was a FP7 European funding to examine that across Europe. And there was a debate, and there was, within that research, in the latter end, there was two camps that were formed. There was the skill mix narrative, which wanted to have nurses as a degree profession. And there was a counter argument, headed by Professor Simon Jones, who's now at NYU. And I was definitely in the other camp of skill max. Now, skill max was to maximize the skills available in an interdisciplinary team. Now, again, I feel quite vindicated. During COVID-19, skill max was what they used. And the reason I was against skill mix was for this. If their argument, i.e. the RCN and the NMC, the RCN, it was the RCN's argument. The RCN's argument was that the higher the skill, the better the outcome. My argument against that was, well, why have nurses at all? Why not have everybody doctors? Because they're your most trained and most qualified. The reason we don't is we can't afford it. We can't afford it. No health system could afford it.
And also there is a need for interdisciplinary teams. Everyone has a role to play.
Precisely. And also you would say is that I often say that, what is the function of doctors? They're either doing, if you're a surgeon, you do surgery. Most of the time it's diagnosis. But then they have AI. AI's got to transform medicine, particularly predictive modeling. We know that the groups that are most at risk.
Yes.
We know that, for example, evidence is well founded. I'm Scottish. I know I'm hiding my Scottish accent quite well to the people that are listening in. I have a natural predisposition to certain things. People of certain ethnic origins have not. If you're Black or Asian, you have a natural predisposition, unfortunately, to diabetes.
Yes.
It's accepted. That's a genetic predisposition. It's no racist. It's a genetic predisposition. I, by being of Semitic background, have a predisposition to diabetes as well. So unfortunately, people that are white, depending on your ethnic group, you've got a predisposition to it. Now, if you have predictive modeling, you can put in systems in place to warn, to monitor that person. That is, you don't need to go to a doctor for that. The technology manages that.
Yeah.
So I mean, if you're listening to this and you're 21 or younger, you're going to live in very exciting times. I want to give you, this is more to our audience. Yeah. When I was young and went to school, we still used abacuses, and we had beads, had metal beads, had two wooden. I might have to explain what an abacus is to the audience. You had a small rectangular block, and in between the blocks, it wasn't filled with wood. It was filled with long metal poles, thin metal poles, and you had beads on the poles, and you learned to count. And then about 1973, 74, maybe 75, this wonderful thing came out, which was very expensive, called the electronic calculators, which we thought came from the moon. We thought this was the most cutting edge thing in the world, because we had the abacuses away calculator, even done logarithms. We thought this was amazing. This is the most amazing thing. You used to have logarithm books to work at these calculations. Amazing pieces of technology. Amazing. Now that seems like from the Stone Age. The internet, you can go in there. If someone said to me at 7, 8, 9, 10, 11, 12, you'll be able to have a computer and you'll be able to ask it questions, type it in, and it'll answer. I guarantee you'll have systems. I might not live long enough to see this, but you will, where you have this already when you speak to Alexa and you say to Alexa, put on something, and she'll give you an answer.
Yes.
You ask Alexa a question, she'll give you the answer. It's already here. It's already here. It'll just go to the next stage, being virtual. You may well have a hologram. That may well come, or even something even better than that, or more sophisticated than that. Those think all the holograms were so 2040. They were so 2050. They're just old-fashioned. What do you mean holograms? It might be interactive, but it will not be done in the way that we've traditionally done them. They'll say, see these humans, they were so inadequate. And we might receive a point where we get to that point. So technology is cheap in real terms.
Yeah, in real terms.
In real terms. Alexa, God love her, she's flashing at me when I shout her name. When I say Alexa, she listens. See, she speaks back to me.
Sorry, I don't know that one.
You might not hear her saying, I don't know that one.
Yeah, you can, yeah.
So Alexa, when you speak to Alexa, it's interactive already. We're already surrounded. We're there. It's going to be very interesting times to use young people in the audience. That's all I'm saying. Very interesting. Yeah. So I've taken up. Yeah. So I've taken up so much of your time. I overrun. I can talk. So apologies.
No, but a lot of interesting things to think about. And I think one of the things with tech, and I'd like to close with that, is I was recently writing a paper as well on telehealth and maternity. And one of the things I was highlighting there is that the problem with why a lot of people find tech as expensive is because you initially need to put it in place for then everything to flow. But what people don't see is that once you've made that initial investment and the technology is placed, your cost in terms of daily usage or your uh, daily healthcare costs drastically go down. But somehow that side of things people don't see, but they end up seeing the fact that you have to spend so much money to get your systems in place, to put the technology in place. So,
Precisely. I
yeah,
mean, it's so short-termism. The initial costs can be high.
yeah,
The long-term benefits far greater by the cost. I'll give you an example just now. Often what happens in the military is applied in the general
mm,
population. So
yeah.
penicillin is created during the Second War, no for the treatment of the population, but the treatment of soldiers and sailors and airmen. That's why it becomes mass production, penicillin, antibiotics. The space race produces microchips, Teflon, whole host of things. That very state actors competing against each other. Massive. Now, the military are working on drones, micro drones, small drones. And you're going to say, well, why is that going to be? How does that affect? Well, transporting lungs, for transplant, and for anything. They're now developing, you'll know this, artificial skin.
Yes.
Growing organs. Now, I'll give you the heart valves. Where do you think most of the world, what country do the world's heart valves come from?
I have
What
no
country? It's India. So they're purchased. Someone dies, they'll buy heart valves from the cadaver. The heart valve doesn't have to be alive. It has to be able to be a heart valve.
Well, yeah.
Massive. It's a public. It's a public, and it's a public business, but very much a private business. Often goes under the radar. Most of the illegal trade comes from India, massively, and China as well. So because they've got the most
population.
They've got most of the world population. India, because of the genetic composition, because that's most Europeans come from the Indus Valley somewhere. So genetically, it's easy for transplant.
You can trace back at some point. Yeah.
You can trace back at that lineage within a 1,000 generations. Most of them within 100 generations, actually. So why is that important? So if you have that, you're able to grow heart valves, grow them, human heart valves and you can actually, it's now going to be such a stage that you can grow them from the person's cell. Sounds like science fiction.
Yeah.
It sounds like science fiction. But then you don't have the costs for rejection.
Success rates will go up.
Then you have the curse. Fortunately, I'll probably be dead by this time, but this is for a young audience. You will have longevity issues, which will be unparalleled in human. The world's population, when I was born, was under 4 billion. It's now between 7 and 8 billion. It's now that it's mostly due to longevity. People, when I was born in 1967. Between 1900 and 1967, the life expectancy went up from 32 to about 63. It was going up by 8 months every year, 6 or 7 months between that 67 years. Between 1967 and 2020, it's not went up by 8 months.
No.
But life expectancy is now in the 80s.
Yeah.
Not the 60s or the 70s, but the 80s. Our head of state, as we speak, is coming up to be 95. Her husband is going to be 100. Now, this was incredibly rare in the past. Now, the previous longest monarch in the United Kingdom was the Queen for 64 years. She dies when she's 82, which is younger than our average life expectancy
Today.
is today. Now, what you're seeing happening in India and Africa and China is the catch up in terms of mortality. That's going to put massive strain on all the health systems and the whole world systems. It becomes like a catch-22. The more successful you are,
the more challenges you face in terms of things like
I want to close on one point.
Yes,
80% of the resources are used by about 18%. 82% of the population never use health. Normally. They only use it there will be some people that throughout their entire life never go into hospital. They maybe go to the doctors occasionally. And I'm talking about people with a long life.
long life.
So remember, health systems aren't fair. By their nature, they're inequitous. So we always have to remember that. Over when you're talking about bottlenecks, is understanding there's no simple solution. But if there is a simple solution, it's simple lean systems. Sorry, I've taken up so much of your time there, an hour and a half. I can forget I can talk. I need no encouragement to talk, folks. I need no encouragement. But I hope this has been useful.
Yeah, it's been lovely and a lot of points to think about. And I think a lot of well-framed arguments and things that I've been thinking about a lot. And, I'm glad that we've got it out in conversation, especially the efficiency part of it. And the fact that the only way we are going to be prepared for the future is if we do get in technology, AI, and a lot more innovative systems. And otherwise, we are always going to be underprepared for whatever comes next. So
once we get rid of the fax machines in NHS, I know. I know.
That's a good fact I learned today, by the way. I had no idea.
The fax machines, you just put NHS fax machines, they're the largest donors in the world. In the world.
So, yeah, I'll look that up, but it's been lovely talking to you. And thank you so much for this.
Angeline, it's been great. My pleasure. My pleasure.
Thank you.
I'll be in touch during the week, by the way, because it's stuff we've got to talk about. But I'll love you and leave you. And a good day to everyone else. And take care, Angeline. And I'm going to leave just now. Is that okay? Bye-bye.
Bye-bye.